So thank you so much for including me in this session. It's really my pleasure. I'm going to be discussing sex disparities in the management and outcomes of cardiogenic shock from the RECOVER-3 registry. Here are my potential conflicts of interest. So we know that women with ST elevation myocardial infarction continue to have about a twofold increase in adjusted in-hospital mortality. We also know that they tend to have more risk factors, more atypical symptoms that probably contribute to this increased mortality, delayed presentations and treatment, and less guideline recommended treatment, including PCI. You can see from this large registry that the increase in mortality specifically affecting the young female patients, more so than those that are older. And comparing young patients to older patients, you can see again that there is less PCI being performed, as well as some of the other performance measures, all obviously contributing to worse outcomes. In the context of acute myocardial infarction and cardiogenic shock, we've seen very similar findings. So younger patients have a higher mortality, they have more comorbidity, and they undergo less aggressive treatment, less coronary angiography at any time, less PCI, less mechanical circulatory support. And you can see that this is nothing new. This is looking at the past 2 decades, back to 2000. Male patients here, in terms of the trends in mechanical circulatory support use, here female patients, and there have been these disparities, this difference over time as a percentage of patients presenting. Female sex in this particular analysis was a predictor for higher in-hospital mortality, and the strongest predictor of mortality was not undergoing PCI or mechanical support, which is exactly what is being used less frequently in our female patients. Here are the predictors of death in women. No PCI, no mechanical circulatory support. You can see that this is amongst the strongest predictors of mortality. So withholding therapy in our patients leads to higher death rates. Interesting trends over time, 2000 to 2017, in terms of the rates of admissions by sex with AMI and cardiogenic shock. Here are the male patients, here are the female patients. An increase in the number of male patients. The slope is not as steep in female patients. Not entirely sure the reason for this disparity. I don't know if it's female patients not presenting, delaying presentation, perhaps higher mortality in the field prior to coming to the hospital, or simply a lower incidence in the female patients. The good news, though, is that the mortality trends have been on the decline overall, and the difference, the gap between men and women has been narrowing. So that's the silver lining in all of this. So what kind of information do we have in terms of looking at these sex differences? This is the shock registry published back in 2001, so quite old, but I still think there's some very good information. This is close to 1,000 patients, 36% are female patients. What we see is, beyond the fact that women have more risk factors, they do tend to have more acute complications, more severe mitral regurgitation, more ventricular septal rupture. And in terms of the mortality overall in the series, it was 61% mortality rate, women 63, 59% in men. It was not different, but clearly you can see that there are some numerical differences. Now, obviously, patients that undergo revascularization, whether female or male, had better outcomes than those that were not candidates for revascularization. And again, on the basis of either revascularization or no revascularization, there were no differences in mortality between the sexes. This is from the randomized IABP shock trial. Again, looking at sex-based differences, same message, higher risk factors for our female patients. Another interesting observation is that they come with lower systolic blood pressure, diastolic blood pressure compared to the male counterparts. And you can see that there is a slight excess mortality here on day 1 that tends to narrow over time. Overall, there's no significant differences between the sexes in terms of mortality rate. And in fact, female sex was not an independent predictor of mortality. So overall, I think we can say that in the context of cardiogenic shock, we're really not seeing major differences in death rates between men and women. There are differences in how they present. It seems like they have more shock when they come in. So moving on, this is from the CVAD registry. So we're now looking at the use of Impella, and this series was trying to evaluate the timing of the Impella use in these patients with AMI and cardiogenic shock. Overall, earlier use of Impella, so before PCI compared to after PCI, you can see that there is a significant benefit in mortality from earlier use of Impella support. Now, extending this to a sex-based analysis, again, we're looking now at survival. So survival tended to be slightly lower in the female patients compared to the male patients. But interestingly, using the Impella support pre-PCI had a greater mortality benefit in women, and that was significant compared to the male patients. Trends were similar between the sexes. So this is why we went on. We wanted to evaluate this similar question, the Recover 3 registry. This is a post-market registry at 45 sites in the United States and Europe. Patients included in this registry were recruited between 2017 and 2019. So this is a contemporary series. And again, our intention here was to evaluate the timing of Impella placement on outcomes by sex. So we identified 358 patients, 23% being female patients. And in terms of the breakdown here, pre-PCI use versus post-PCI use, it was about 50-50 for the female patients, 60% pre-PCI use for the male patients, 40% post-PCI. And again, this is clinically driven. Some of the differences and looks at the baseline characteristics, not much in terms of differences, the main being difference in body surface area. Looking at some of the hemodynamics, again, we're seeing in our series that women had lower mean arterial pressures compared to male patients. You can see that here, they tended to be more anemic, but otherwise the populations were well matched in terms of the presentation. Procedural characteristics, more women first go to balloon pump before escalation to Impella support, 22 versus 13%. And when Impella is used, much more frequently, we're seeing the Impella 2.5 being used compared to Impella CP compared to male patients. And the other big difference here is that we're seeing that the duration of Impella support tends to be longer with or shorter in female patients compared to male patients. In terms of the outcomes, where women, we looked at the impact of escalating inotrope usage, and you can see as you escalate inotropes, the survival is dismal, particularly in female patients, so 19% survival compared to 31% survival for patients on more than 2 inotropes. So worse, apparently, or as it appears in the female patients compared to the male patients. And also the timing of Impella use, so pre-PCI usage compared to post-PCI usage of Impella was associated with a survival benefit in female patients that we did not see in the male patients. And that really speaks to trying to address the pathways of management of cardiogenic shock overall for our patients, but specifically for female patients. This has been published in our journal, the Society. We did look at some of the independent predictors of mortality, specifically in female patients, and the escalation of inotropes and vasopressors prior to the use of Impella was an independent predictor of mortality. In fact, the strongest with an odds ratio here of 3. So clinical implications, what we can say from the data that I've shown you, women are older, they have more risk factors and more complications. They do have a higher mortality following ST elevation myocardial infarction, but in the context of cardiogenic shock, mortality are very similar across the sexes, but PCI and mechanical support are used much less frequently in female patients. Early mechanical support with Impella before the use of inotrope and pressor escalation may provide a survival benefit, particularly in female patients. Some of the reasons, I think, behind this clinical benefit, I think makes sense. Avoiding some of the cardiotoxic effects of inotropes and vasopressors, reducing ischemia, myocardial ischemia. And at the end of the day, I think the message is consistent here. I think the biggest gap here is trying to define the optimal pathways of care in our patients, and especially in our female patients with AMI and cardiogenic shock. Thank you so much for your attention.